Um, Hello and good morning, everyone, once again. My name is Sandra Chilengi Sakala from the National Health Research Authority, and I will be your host and facilitator for this morning's meeting. I wish to say hi and welcome to everyone on the platform. This is our COVID-19 monthly research dissemination meeting, where we disseminate COVID-related research results. So for this month's meeting, we were scheduled to have 3 presentations, but as at yesterday or the day before, we could only confirm with 2. But also this morning, we have just been notified by our colleague, Keston Liambai, who's supposed to make the first presentation, that due to unforeseen circumstances, he's unable to join the meeting and to make the presentation. So we'll defer it to next month, meaning that for today, we are going to have we are going to just have one presentation, and that will be from Ms. Mwiza Hambokoma of CIDERS. But just before we get into the meeting, I would like to encourage all of us to introduce ourselves in the chat box by writing your name and the organization you are coming from. I also want to say that we can use the chat box for any other form of communication. It can be an inquiry. You may have a question for us at NHRA, or it may be you want to inform the audience of this meeting about anything from your organization or indeed anywhere. You can use the chat box. You are free to use the chat box, and we'll all get that information from there, meaning that from time to time, each of us will require to just check what's in the chat box, just in case there's important information for us. We will, because we have one presentation only, we will not be too strict on the 10-minute time presentation. And so you are privileged, Mwiza. You will have all the time in the world to tell us all the things your research was all about. So at this point, may I invite our CEO and Director, Professor Godfrey Biemba, to just greet us and welcome us to this meeting. Prof. Biemba, the floor is yours.
Thank you so much, Sandra. I'll have to apologize where I am. There may be some noise in the background, but I hope you can hear me. Can you confirm, Sandra, that you can hear me? Can you hear me?
Yes, can hear you, Prof.
Okay, perfect. So yeah, so let me recognize the heads of research institutions that I can see on the list. Specifically, I see Dr. Skazwe from CIDERS. I can also see Dr. William Klembe. And if I've not seen you as a head of a research institution, you'll forgive me in terms of protocol. I want to recognize Mwiza, who is going to present, and all those that are attending this important dissemination. I would want to encourage you to tell others about this dissemination. We created this forum to enable researchers who are doing research in COVID to be able to present their results. And that was just not for the sake of dissemination only, but so that we are able to see those results that are policy or program relevant, and be able to package or repackage such information for those that are in the front line in response to COVID-19, but also for information of the policymakers as far as COVID response is concerned. You will appreciate that we have a new government, and the new government has put premium or priority on the response to COVID-19. And you'll realize, or you probably know, that at the highest level, the president of this country has even appointed a COVID-19 advisor. And I think that is speaking to the importance that is attached to our response as a country to COVID-19. Just to remind you also that there has been a number of countries now where the fourth wave has started. And so we do predict that there's a possibility that we'll have a fourth wave. And so I would want basically all of you as researchers to mobilize ourselves to respond to this pandemic as we have been responding. I would want to basically urge you to advocate for those of us who have done studies on COVID-19 to come forth and present at our monthly meetings, which occur on the last Wednesday of every month. So with that, I want to invite you all to listen carefully and enjoy the presentation that Mwiza is going to make. Thank you so much.
Thank you so much, Prof. Biemba, for the welcome remarks. Mwiza, the floor is yours. I hope that you'll be able to share screen from your end. If not, please let us know. We can't hear you.
Okay, good morning. Thank you, everyone. Sorry about that, some technical challenges. I think I should be able to share my screen. You can let me know if it's showing.
Yes, we can see your screen, Mwiza. You can go ahead.
All right, thank you very much for having me and giving me this opportunity. I would first like to begin really just by mentioning that this study, we started our data collection in February this year. And I think the last person that we enrolled ended in May. So basically, we're still trying to analyze our findings. So what I'm going to present to you are really some preliminary findings and not conclusive findings. So as you can see, I have a very long title there. It's Information and Structural Barriers to Uptake of Preventative Behaviors among healthcare workers working in both isolation and non-isolation sites during COVID-19 in Zambia. And the people who helped me so much with this study were my colleagues Gomezani Ngoma and Evelyn Ngandu. Okay, I will jump straight into it. So basically, I'll start by giving you a very brief background, then move into the methods, have some results, and then I can actually open it up to discussion for you because like I said, I'm really just presenting some preliminary findings and it would be great to hear from other researchers who are on today, maybe to give some sort of guidance or maybe to see what I can really look for in my results. And then I'll give you some acknowledgements and we'll end with a Q&A session. All right, so basically the background to this study was really, I wanted to find out, we know that healthcare workers are really at a high risk of contracting COVID-19, basically because of the nature of their job. And I wanted to explore, what do healthcare workers know about COVID-19 in terms of prevention, treatment, management? What skills do they need? What are their attitudes at working during COVID-19? And also, what is their ability now to practice infection prevention practices during COVID-19? So one of the objectives I had was to describe the experiences of them working in the isolation ward In particular, we looked at Levi Mwanawasa, and the non-isolation facility, we looked at Chilenge Hospital. I also wanted to find out how healthcare workers practice infection prevention. So for my social demographics, basically we had 7 males and 13 females, and all of them were nurses. For some reason, I was not able to have any interviews with any doctors. So I wonder if that might have had an impact on my results, but we'll see what comes up. In terms of the methods, I am a budding qualitative researcher. So my main interest is using qualitative methods. I carried out 20 in-depth interviews via the phone. Unfortunately, this was during the peak of, I think, wave 1, wave 2, and we really couldn't meet with the healthcare workers. So we had to do this over the phone. So my preliminary findings that I'm sharing with you today includes things like what knowledge do they have, what we thought were some of the gaps that they could have, also the training they received and some of the gaps that we found, and also what they presented to us as their experience working in the facilities during COVID, and also some of the challenges they faced, and also the recommendations that they gave to us. So in terms of knowledge and the gaps, although the gaps will come a bit later. So in terms of knowledge, we asked them what exactly did they know about transmission. So at least majority of, actually all of our healthcare workers were able to tell us what they knew about the transmission. I picked up one particular quote there that says, actually COVID-19 is transmitted through droplets that can be saliva or other droplets. In terms of prevention as well, we got very good answers. They were all able to tell us about what they know about prevention. That's, you're washing your hands with soap, sanitizing your hands, mask wearing, and wearing of PPE. They were basing that on themselves working in the health facilities and also having isolation wards. Again, this was based on them working in the health facilities. In terms of management, again, we saw that they do have a very good idea of how they manage patients during COVID-19. And they gave us almost like a step-to-step what it is that they do. So they mentioned things like, when a patient comes, they do the screening. If you are tested positive, you are put either in an they'll isolate you from the rest of the general public. They'll also then judge whether you are symptomatic or symptomatic, and then follow those laid down guidelines. So at least we were able to see that of the 20, majority of them did have quite substantial information about management. What we perceived to have been one of the knowledge gaps was that we did notice that nobody did mention anything about coughing etiquette, basically either using a hanky or using your elbow. It may or may not be a big deal, but we thought it was something, we did realize that nobody did mention anything about that. And we did also notice that nobody actually mentioned that as they are doing the management, the guidelines that we've read about clinical management for COVID do mention that one of the things they're supposed to do is pay particular attention to people who might come in who have high blood pressure, who might be diabetic, and also the elderly. So we thought that could be a knowledge gap because nobody mentioned this at all. And then in terms of the training received, we did note that 7 out of 10 participants in the isolation ward said they received training or some sort of orientation, whereas 10 out of 5 healthcare workers in the non-isolation ward mentioned that they had received some sort of training or orientation. When we did ask them what their training was or orientation was, they mentioned that majority of the topics was on swabbing a patient, was on donning and doffing of the PPE, and also on oxygen therapy. But the one thing that we did note, however, was that for our colleagues in the non-isolation ward, nobody mentioned any training on oxygen therapy. And oxygen therapy really only came out for our participants who were working in the isolation ward. So I just picked out some quotes there. So this is is a person who says, okay, that training, they were teaching us on donning and doffing, and also on oxygen therapy, how to commence oxygen therapy, and how to protect ourselves from COVID. And then we have this other person who says, no, I did not get any training. I learned through my friends. So I think those were some of the gaps that we noticed. Not everybody got training, and quite a few, especially from the 9 isolation facility, did mention that whatever they knew about COVID, they had either learned it from their colleagues.
This is not fair.
Okay. So in terms of work experience, what we noticed, what was really coming out a lot, we did realize that maybe the way we asked the question might have been a bit misunderstood. And we noticed that when we asked about their work experience, a lot of our healthcare workers were talking about how they felt, their feelings during the pandemic, during wave 1 and wave 2. So what some of them were saying was that, when this surge happened and there are so many numbers of people, it was really overwhelming. It was overwhelming to them. It was overwhelming to the system, but they were also quite afraid. Like I think I one or two one or two participants who mentioned that they were so scared to even, work with patients who came in, especially those who you could see were critically ill, especially if they didn't have enough PPE or if they didn't have enough gloves. But I put out this quote that says, we had that surge that happened. So the number of patients, critical patients, did increase, and we would see even maybe 5 or more patients a day. By then, we were only 2. So this person is talking about their particular facility that were able to do this procedure. So it becomes cumbersome and fatigue used to kick in. Yes. So with the second wave, the anxiety wasn't there because we now understood the respiratory disease better, only that we had less manpower. Then we noted some challenges. So what we did here was really just to show like a Venn diagram to show the challenges faced by those in the isolation wards and those in the non-isolation wards, and the challenges that both facilities faced. So we can see there in the non-isolation ward, what they were saying was that they lacked the knowledge on how to manage critical patients. So it's from these guys that we were hearing, they were saying things like, if a critical patient comes and this patient maybe needs oxygen, not everybody knew how to give the patient oxygen. So they felt that they didn't have enough knowledge on how to take care of critical patients. They also noted that another one of their challenges was that they didn't have enough ambulances. So again, if a critical patient, from the community comes and is rushed to the facility like Chilenge, you find maybe the ambulance is already out with other patients, and then that really does prove to be a challenge. And then the common challenges they faced were erratic supply of PPE, and also obviously the overwhelming number of clients. Like I said earlier, these interviews were conducted, I think, just at the beginning of between the first wave, the second wave, thereabout, not necessarily the third wave. Then we have our colleagues from the isolation ward who mentioned that the challenges they faced were long hours in PPE, and also the lack of readily available medication to treat diabetes and high blood pressure. Again, there are so many challenges coming out, but we thought these were just some of the few that we could share. Like I do remember one particular person did mention that one of the issues with the PPE was that the PPE was too small. So I thought that was also an interesting finding because the participant mentioned that the PPE was very small for them, and this was a very tall person. So it meant that they were now risking their lives because they had to wear ill-fitting PPE. So this one, I would just like to clarify that these were recommendations from the participants. The last question in my interview guide was asking them about their the recommendations of what they thought could help them, either work better or protect themselves from contracting COVID-19. So some of the things they were mentioning was that they would love to have been offered some sort of hazard pay or, motivation in monetary form. They mentioned that it would be great if there could be more training and increase the number of healthcare workers in specialized fields. In particular, they mentioned infectious diseases, in critical care, in public health, and also mental health. And the mental health one as well, we found that very interesting because in some of the questions we were asking them, a lot of them did mention that it would be great if they had people to do mental health for the patients, but also for them as healthcare workers. And then they also recommended that it would be great if there could be adequate and a consistent supply of well-fitting PPE, of test kits, and in particularly they really mentioned having the rapid diagnostic test kits. They preferred that to having the PCR tests, and also the medication for comorbid diseases like diabetes and hypertension. They did also recommend that it would be great to have, more products to enhance infection prevention. So that's your basic, running water, soap, hand sanitizers around the facilities, and gloves. And again, like I mentioned in the second point, they also were very keen to have mental health support for themselves, as they felt that, I think they experienced a lot of trauma. I think a few of them did mention that when their clients, so many of their clients died, and this really did affect them mentally. One of the things that also came out quite prominently, when we asked them, like, how do you think, we can protect you from contracting COVID? They mentioned that they felt that the community, all of us, needed a lot of mass sensitization on COVID to demystify the disease, to let people know what the treatments are and other misconceptions. So a lot of the healthcare workers kept on mentioning that community sensitization needs to be ongoing, because they felt that a lot of patients were coming into the facilities and would still have a misconception that COVID wasn't there. Again, I remember one of my transcripts, I think someone did mention that, they had patients who are still having this mindset that COVID is only for the rich or the upper mwambas, and forgetting that it's really affecting everybody. And they also, again, in line with that sensitization, they wanted just, give basic information, basic COVID preventative measures to the community. And another thing they were asking for is to shorten the work hours, especially when they're dealing with COVID patients. Um, they felt it would be better to, do the rotation, so that especially those who are working in the isolation ward, to do a very short rotation instead of them being at the facilities for so long. So basically, from this study, I think some of the three main takeaways that we are finding was, we believe there is some insufficient training. There's an insufficient mandate in terms of supplies and equipment to meet prevention needs and to treat COVID-19 patients and NCD patients. And we also think that, the anxieties that COVID brought lucky enough, did reduce in the second wave, because at least by then the healthcare workers were a bit more confident and they knew how to handle the COVID cases. But I think there's still so much from the data that we're still looking into, but we just thought that we would share what we have so far with you. So I would like to acknowledge my supervisors and my project team, and also really just a special thanks to the study participants. I must admit it was a bit challenging to recruit them. I think some of them were a bit reluctant to join the study. I think we had about 7 or so participants who just did not want to take part. So for those who took part, we are very grateful. The PHO's office, the DHO's office, and the hospital hospital authorities as well. And also I'd like to thank the funders who provided the funding. That's the Royal Society for Tropical Medicine, who gave us a grant to conduct this small study. So thank you very much for your time. I will now leave it to question and answer. I was really prepared for the 10 minutes. So thank you very much for your time and your attention. Thank you.
Thank you so much, Muiza, for that wonderful presentation. I must say, I love the simplicity of your presentation. It's very easy to follow and understand. At this point, may I invite questions, comments for Muiza? You can raise your hand or you can type the question in the chat box. I'm not seeing any hand. Okay, I have two hands. So let me start with Dr. Kilembe, and then we'll go to Prof. Biemba.
Thank you so much, and thank you for the presenter for the presentation. My comment, especially that you're thinking of how to move forward with this study, is basically the realization that COVID-19 has been a moving target since it started. And so you described that I think some of these surveys were done around the time of the first wave and the second wave, which was late last year into this year. What would be your comment in terms of moving forward, conducting a follow-up analysis? Because as I say, it's a moving target, so things may have changed. I think training may have improved between the second and the third wave. And also the fact that PPE was more readily available. You know, initially there were restrictions in terms of travel and air freight into countries, and now, you know, between the second and third wave, perhaps those things changed. What would be your comment or consideration in terms of interviewing the same individuals to close the loop now? I mean, do you see an improvement? I see that as a natural flow of the idea of this study, because I think presenting the data the way it is might be a little misinforming, and I think it would be prudent to probably get some follow-up, you know, information from those particularly that you interviewed, and indeed you can actually increase your base of the people that you interview. So maybe just a comment around what you think about that idea.
Okay, thank you very much, William. Yeah, and you are really right. You know, I did think about that as I was presenting. You know, it's been quite a while now. I think that's something I could really look into. I could probably sit in, you know, with my supervisors and see what we could do. You know, maybe see if we could squeeze in a few more interviews. But I really do like that idea. Thank you, William.
Hello,
Yes,
Sandra?
Prof. Biemba. Yes, Prof.
Yes.
You can go ahead.
Okay, so thank you so much, Muiza. Just to thank you for that excellent presentation, very comprehensive. I apologize, I hope you can hear me. There's some background noise, but the question I have is a very small one. In the last slide, you talked about inadequate mandate. I just wanted to understand what that meant. Some of the issues you mentioned was inadequate mandate. What does that mean?
Okay, so here, my line of thought was really that you correct me if I'm wrong. From my understanding, I realized that we don't. So one of the things I'm trying to do also with these findings was to try and do like some sort of a policy brief that is targeted specifically to healthcare workers. So that was what we meant by not being a mandate that looks at what was it again? That looks at the supply and equipment and also the training. So that's kind of like my line of thinking at the moment. Like we need like a specific policy. So again, you can guide me if I'm wrong. I did try, the only policy I did find